Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner, and I am the editor-in-chief of CMI Comms and an infectious disease physician in Switzerland.
And hello and welcome to Breakpoints. My name is Erin McCreary, and I'm the Director of Infectious Diseases Improvement and Clinical Research Innovation at UPMC. Today, we are bringing you the first ever collaboration podcast between Communicable and Breakpoints, the start of what we hope is a beautiful relationship where we plan to bring you 2 Journal Club episodes each year. For our first one, we're discussing the MSSA and PSSA domain of the SNAP trial, which stands for Staphylococcus aureus Network Adaptive Platform Trial. This was presented at ESCMID Global in a very cool new trial format, where the authors presented the data, and then 2 moderators provided commentary, and then there was a long time for audience questions, which was fantastic. And we'll talk through some of the dialogue of the questions the audience had for the authors. So let's get right into it. Our first guest for this episode is Professor Steve Tong, who's an infectious diseases physician with the Victorian Infectious Diseases Service and a lead of the Clinical and Health Systems Research Discipline at the Doherty Institute. Steve is the co-coordinator and co-global lead of the SNAP trial. He's a friend of the podcast. So Steve, welcome back to Breakpoints. And then I think this is your first time on Communicable. So welcome to Communicable.
Great to be here. Very excited. First time here, but long time listener to Communicable and Breakpoints, of course.
We're so honored. And next we have Josh Davis, infectious diseases physician at John Hunter Hospital in Newcastle, Australia, and the head of the infection research program at the Hunter Medical Research Institute at the University of Newcastle. Josh is a clinical trialist, and together with Steve, he's global co-lead of SNAP. Josh, welcome.
Thank you, and thanks for having Steve and I on to do one of our favorite things, which is talk about Staph aureus and the SNAP trial.
Yes, we're thrilled you were both here on both Communicable and Breakpoints. It couldn't be better to start off our collaboration like this with the two of you. So as our listeners know, on Communicable, we start these episodes with a sort of get-to-know-you question, thanks to Josh Davis, for our guests and also for our hosts. So we've all been recently traveling to Vienna for ESCMID Global, but also maybe elsewhere. What is an experience you had while traveling that keeps coming back to you? Steve?
I had the privilege of going to Budapest after Vienna for ESCMID. And one of the things that struck me was how much the history of somewhere plays out for people's lives. And in particular, Hungary has gone through the history of colonization or being overtaken by lots of different other groups. So, for example, the Turkish people came for 150 years, and then there were the Habsburgs. There was also a time where Nazi Germany occupied Hungary for a year, and 400,000 Jewish people were taken to concentration camps. And then there was the Soviet Communist Party came for about 40 or 50 years. And that's had a very indelible impact on Poland, Hungary, and Budapest. So you can see the Soviet-style buildings at places compared to the buildings from the Habsburg period as well. So it just struck me that our politics actually does impact upon the lives of people around the world.
That's very interesting. That center of Europe is indeed totally rich with human experience and mixing of different peoples and conflict, lots of it, unfortunately. Josh?
Mine is a lot more pedestrian than Steve's, both literally and metaphorically, in that when I was in Vienna just the week before ESCMID, I did a half marathon there, which was exciting for me because it was my first international running event. And it was also the first time I've ever run in 0 degrees temperature, which was an experience that I keep thinking about, not necessarily in a good way.
Oh my gosh, you're such an Aussie rubbing it into us Northerners. 0 degrees. It's like my life half the year.
I was going to say, that's one of the most Australian thing I've ever heard. I traveled, but I ran a half marathon. You guys are such a fit society. So I'll talk about mine, which was my recent trip to Australia. I'm going to maybe potentially embarrass Steve a little bit here, but it meant a lot to me. I was there in February, and Steve invited me to go meet his family, which was really just so special because we travel all the time for work and we build these global collaborations and we're always at these conferences. And it's just really meaningful to me to remember that we're all people too at the end of the day with families. Anyway, I had the pleasure of meeting Steve's wife and his 3 beautiful kids, and it meant a lot. So thanks again. It's one of my most favorite recent travel memories.
For my travel memory, I'm actually going to go with you on that. I mean, we all were just in Vienna for ESCMID Global, and there were some amazing things that happened there. But the memory that keeps coming back to me is actually my trip on the way to Vienna. And my husband will laugh when he hears this because he'll say I'm virtue signaling, which I fully own, because I'm going to tell you, I took a night train to Vienna, and I'm very proud that I didn't fly to Vienna. Anyway, on this night train, I was in a compartment with this amazing woman. We just totally bonded. She was just such a gentle soul. We had our little couchettes side by side all through the night, traveling from Zurich to Vienna. And she was just such a dear woman. She was going to visit her mother, who was sick in Vienna. And every month she takes that night train and she goes and tends to her mother. And she was so kind. I spilled coffee on her in the morning coming down the ladder from the couchette, and she was such a dear. I think I made a new friend, and I'm very excited about that.
I have 0% trouble believing that story, Angela. I feel like you're the most wonderful human to talk to randomly on a train, so I'm sure you had a great time.
You know, I really hope my husband's listening to this one. I love it.
Hey, Ben.
Thank you. Virtue signaling all the way.
Hi, Ben. Thanks for letting Angela talk to us about staph on her family vacation. All right, let's talk about Staph aureus. Right. Let's get to SNAP.
Yes. So first off, here are some things to know. None of us have any commercial conflicts of interest related to the drugs that are going to be discussed on this episode. I myself have no connection to SNAP at all, except as an avowed admirer of the platform.
Well, I feel like Steve and Josh, the obvious disclosures, they designed the trial in a very cool way, which we'll talk about later. I had the honor and the privilege of serving on the DSMC, or the Data Safety Monitoring Committee, for the SNAP trial, which I think we'll touch on later about that role and how I haven't talked to Steve or Josh because we can't with the integrity of the data and the trial. So this is actually very neat for me. This is my first time earnestly talking to them about the data, even though all three of us have been very intimately involved in this for quite some time now.
Apart from my involvement in SNAP itself, I've served on an AstraZeneca advisory board for a staph bacteremia prevention study, and we can claim payment for that. And I receive royalties from Up to Date for editing some Staph aureus-related articles.
Steve, did you know that your CMR paper on staph, you guys both, right? That is the most cited CMR paper ever. You guys know that?
Amazing.
You guys are
nice.
You guys are so cool. I was looking at CMR the other day for something because I like reviews, because I'm a nerd. Anyway, you guys are so awesome. But Josh, any COIs you need to talk about?
Yeah, no, nothing to add from me.
Perfect. All right, guys, congratulations. You should be so proud of yourselves. The largest trial of Staph aureus bacteremia ever. You all have enrolled more patients than all previous Staph aureus bacteremia randomized clinical trials combined, which is crazy to think about. When you got up to present this at this ESCMID session, you shared that you came up with the idea for this trial on the back of a napkin at a restaurant in Melbourne, Australia, which I couldn't love this more. And then in that, when you sat down to literally back of the napkin out this trial, you said, randomized care is better than random care. And that was the driving philosophy for why you wanted to build this platform. So tell us more about SNAP and what really an adaptive platform trial is for our listeners who may not be as familiar with this innovative concept and how we're moving the paradigm of RCTs. Steve?
So many of the things we do in infectious diseases are just not guided by randomized evidence. For example, whether we use cefazolin or an anti-staphylococcal penicillin to treat MSSA infections, and in effect we provide random care. So SNAP really seeks to randomize these kinds of everyday treatment decisions, and by following clinical outcomes, we can then learn from the process. There's two key aspects to an adaptive platform trial. So adaptive and platform. The platform means that we set up the infrastructure and protocols to study a disease or a syndrome. And in this case, it's Staph aureus bloodstream infections. So rather than only addressing a single question, such as cefazolin versus flucloxacillin for MSSA bacteremia, the platform allows us to address multiple questions in parallel. We often use the analogy of building a football stadium, which allows multiple games or trials to be run. The stadium or platform remains after a question is answered, and it's used for the next questions, and it's a much more efficient approach to clinical trials. The adaptive part of an adaptive platform trial means that the trial adapts as data accrues. So, for example, if intervention A is found to be superior to intervention B, then that comparison can conclude and the results get reported, and new patients into the platform can either all go into intervention A, or we begin a new comparison of intervention A versus intervention C, and then other domains can continue without interruption. And in fact, new domains can be introduced over the life of the platform. One of the key points here is whether an intervention is declared to be superior or non-inferior requires pre-specified stopping rules to be met. So it's certainly not a case of making things up as we go.
Oh, that's amazing. Amazing because in infectious diseases, we just don't have very many platforms like this. It's allowing each participant to contribute to more than one question, like you say, Steve. Average of 1.6 randomizations per enrollment, I believe. So these 4,000 odd patients are actually undergoing more than 6,000 randomizations, which allows us in the medical community and patient community to understand so much more on, of course, I imagine, a very low budget overall. So Josh, can you explain the backbone of the SNAP platform and the domains as they are right now?
Yeah, sure. But before I do, I just wanted to give a quick shout out to the REMAP-CAP trial and the investigators that set up and run that, particularly Steve Webb, because they have been really helpful to Steve and I in designing the SNAP trial, and that's where we got a lot of the ideas about how to do a platform such as this. So to answer your question, the SNAP trial is set up so that patients are first screened for eligibility to enter the platform overall. To get into the platform, you just have to have Staph aureus bacteremia and then not meet a small number of exclusions. Those are that it's been more than 72 hours since the blood culture was collected so that we can intervene in a timely way and there's a chance for an intervention to show its effect if it has an effect. And then secondly, people are excluded if they're for end-of-life care or not for active management. And there's a couple of other more minor exclusions as well, but it's very broad, the inclusion criteria into the platform. And once people are in the platform, they are then screened for one or more domains. So each domain is equivalent really to its own randomized trial. Today we'll be talking a bit more about the backbone domain, and there are other domains that are still ongoing in the SNAP platform, including an adjunctive antibiotic domain, early oral switch domain, and a PET-CT scan domain.
I might just add to that, Josh, one of the things we're really proud about is that children and pregnant women are included in the trial as well. So not all clinical trials include those population groups, and we've worked really hard with our paediatric and obstetric and gynecology colleagues and ethics committees to ensure that both kids and pregnant women can be part of this study.
I think it's amazing because I think you guys have intentionally easy inclusion-exclusion criteria. This is so important because basically all the data we have now are these. If we have a randomized trial in infectious diseases, which is thank you for all the people who have done them. Angela, you are one of these people. You've done some fantastic randomized trials in infectious diseases. But often they are, if we're lucky, 200 or 300 patients, and they have this very rigorous list of inclusion and exclusion criteria, which we've appreciated to date. You want to be safe, and we want to make sure we're doing the right thing by patients and first do no harm. But as a clinician, you then read the study and you're like, okay, here are the 37 things I have to see if my patient meets this criteria before I can then apply these results. And immediately you journal club it on a Monday morning. And I mean, not to use I like a sports metaphor. So Steve, I appreciate that we're building a stadium here. So not to Monday morning quarterback, but then, a bunch of people at my hospital will get together and be like, well, I can't do this for this patient. So this is fantastic because it's like, do you have Staph aureus bacteremia and you're trying to live? Great. Then the results apply to you pretty much. And then peds, pregnant persons, and complex infections. You guys didn't really include any infection source, which is so fantastic. So thank you for outlining the domains and how patients get in and the different things you're studying. But Steve, can you talk to us about how exactly this Bayesian platform randomization adaptiveness works? Because I think, as Josh alluded to, we first were introduced as a community to this Bayesian magic, so to speak, with REMAP-CAP. And I think the foundation of REMAP-CAP, I agree, was so instrumental in what we as a community can now do moving forward and how quickly we can randomize patients. But when we presented those results, I think the first results that came out for that trial were the steroid results, right? And we're like, steroids are probably life-saving in COVID. but it's presented as this greater than 99% probability that steroids are probably better. And I think that confused a lot of people. And when you read the stats section, no one really knows what to do with that. So we want to make sure people read the SNAP results and know what to do with them. So can you explain this randomization and how these stats are reported out?
I can try. The randomization in itself is straightforward. I think we all understand that. And for SNAP so far, it really is just a coin flip. As each participant enters into a domain, they have a 50-50 chance of being allocated to one of the two interventions in that domain. We then have these regular scheduled analyses performed by an analytic team who report back to the Data and Safety Monitoring Committee. These occur after every 500 participants have reached their 90-day outcome time point. And with our enrolment rate of approximately 150 participants per month, these scheduled analyses occur every 3 to 4 months. And each of these scheduled analyses, an estimate of the treatment effect is made. So, for example, the comparison of cefazolin versus flucloxacillin for MSSA for that 90-day all-cause mortality outcome, this gets estimated at each of these scheduled analyses. And it's a treatment effect which is adjusted for pre-specified covariates, including age, country, eligibility, and allocation to other treatments in other domains, and also 26-weekly time epoch. When we use this Bayesian statistical framework, which I agree is a little bit harder to understand, we actually all work as Bayesians, particularly as clinicians. So the example I quite like using is in the diagnostic process. If a patient comes in with a cough and a fever, you immediately think pneumonia is on the list of diagnoses there. And based on that history, you might have what we call a prior of 50% probability that this patient has pneumonia. And then you order a chest x-ray. The chest x-ray shows you solid lobar pneumonia consolidation on the x-ray. And suddenly that shifts your probability of that diagnosis being the case. So instead of being at a kind of 50% probability, suddenly you've gone to an 85 or 90% probability. And that's very similar to what we call here the posterior probability. So we come into the trial with a prior to say that does cefazolin work better than flucloxacillin. We usually set that prior at what we call just a very neutral prior. So it's set at a treatment effect of 0 with a certain distribution around that. And then we get the data, and the data informs on that prior, so that we end up with a posterior, what we call posterior probability of the treatment effect. And in this case, we set particular stopping rules for each of these domains. So in this case, we need to have a 99% posterior probability of non-inferiority or superiority before we stop one of these domains. So there's no p-values, and in all of our presentations and in all the publications, there's not going to be p-values, and the final trial result gets reported as a posterior probability with adjusted odds ratios.
Is it okay if I might just add to that? Erin brought up when people started seeing trials reporting out the probability that this is superior to that is 95% or whatever, and what does that mean? That's the good thing about Bayesian statistics, is it means exactly what it says. It's a different language, right? We're used to hearing the frequentist language, p-values and so on. But actually, when I say a p-value is 0.03, it's actually not clear intuitively what exactly that means. It doesn't mean what people think it means. Whereas if I say the posterior probability that cefazolin is better than flucloxacillin is 85%, it means exactly what the sentence says. So Bayesian is how we think.
I find it easier talking to patients. Like if you go to a patient to say, well, we've got 2 treatments that we can offer you, the p-value was 0.03, they're not going to understand what that means either. Whereas if you say that there's been a big trial that shows that treatment A has a 90% probability of being better than treatment B, which treatment would you like? I think that makes a lot more sense to the patient.
Yeah, no, it's interesting. I mean, we are experiencing a major paradigm shift. We may not be entirely aware of it because we're living it, but we are, I think, in the middle of a big shift from frequentist to Bayesian. I think if you don't know the Bayesian background, it may seem a little intimidating, but like you two say, it's actually more intuitive, maybe more intuitive than the frequentist approach, which is just what we all grew up with. So I'm going to actually just make a quick note here for those who didn't get to go to ESCMID Global and didn't get to see this beautiful beautiful presentation. You can actually see it online. You need to be an ESCMID member. You can sign up from anywhere. It's quite affordable, and the rates are lower for people who are still in training. I didn't get to go to this session. I had to give a talk in a parallel session. There were like 8 other sessions going on. I did not get to be in the room. So I've been watching it online, and it's still quite powerful to me. So coming back to, sort of the PICO, looking at the population of people that you included. We already mentioned the enrollment is super pragmatic, very easy inclusion criteria. You can see this in the platform's concert flowchart that Josh showed in his presentation. You have so far screened, I think, 13,000 people, and you've enrolled more than 4,000. So you've managed to include a third of all screened patients. And that's not an easy feat, as Erin was saying, because these are really, you have staph bacteremia, you're sick. You're a very sick patient, usually. So can you explain a little, Josh, what were the major inclusion-exclusion criteria? How did that work?
So I mentioned briefly before the platform level eligibility criteria. And so we're now talking about the backbone domain for patients with PSSA or MSSA bacteremia. To get into this domain, patients had to meet domain eligibility criteria in addition. But again, there were only few of those, and some were unavoidable. So they were major or minor allergy to either cefazolin or flucloxacillin, or being on hemodialysis or maintenance dialysis. And that's just because generally those patients would be treated with cefazolin after dialysis 3 times a week, and we didn't think it would be right to randomize them to have to get a line put in to receive flucloxacillin. And finally, if they were already receiving other antibiotics that were active against Staph aureus, that couldn't be ceased or substituted. So those were the extra eligibility criteria. That combined with the fact that patients need to be approached and have a consent discussion and give consent. That's why not 100% of patients are in the platform, which is the ideal we should aim for, right? But it's still, as you say, a pretty good proportion that made it into the platform and then into the domain.
Yeah, no, it's really good. And what's also really nice is that you're following patients who don't meet randomization criteria. You have created this parallel observational cohort study. Those patients who don't get into the RCT, they still have a lot to teach us. Of course, one thing we will learn from them is how representative these trial patients end up being. No time for that discussion today because there's so much to unpack already with the actual RCTs. We would need another show just on your observational study, which I'm keeping in my back pocket in the meantime. So moving on to outcomes, what are your primary and secondary outcomes? Josh.
So the platform primary outcome is all-cause 90-day mortality. And we did debate back and forth both the time point and whether it should be all-cause mortality or attributable mortality. But we're using 90-day all-cause mortality. If we have time, we can talk about why. So there's also a number of platform-level secondary outcomes, and they include all-cause mortality at earlier time points, microbiological treatment failure, which is a positive sterile site culture for Staph aureus that is found between 14 and 90 days after platform entry, Clostridium difficile diarrhea, because people are understandably worried about the effect of different antibiotics on that. And then in addition to the core secondary outcomes, each domain has its own additional secondary outcomes. And so for the backbone domains, the important ones there are acute kidney injury and liver toxicity, drug-induced liver injury. There's a couple of others, but those are the most important ones that we'll probably discuss when we're talking about the results.
Awesome. All right, let's get into the results. So we are going to talk today about the results presented for the penicillin-susceptible Staph aureus backbone and the methicillin-susceptible Staph aureus backbone. Steve, we're going to go first with PSSA, and I love this was such a good presentation. You guys did such a good job. But when they got up and said, well, how come Steve's presenting PSSA and Josh is presenting MSSA? You guys said, in true Bayesian randomized fashion, you flipped a coin, so you'll love it. So Steve, we're going to go first. Admittedly, when I first read the trial protocol, I was like, why are they studying PSSA? Because with my United States lens, which is not the best lens, let's be honest, but with my United States lens, we don't test for penicillin susceptibility whatsoever. And in talking to colleagues across the country, this is just simply not the standard. We don't have routine screening of BLAZ, and our labs just don't do the disc testing because for us, it's not worth it, so to speak, that like de-escalation from nafcillin or oxacillin. We don't have cloxacillin or flucloxacillin, but for our global listeners, we're really talking about all 4 anti-staphylococcal penicillins when we're talking about this versus cefazolin. And so we'd give oxacillin or cefazolin and let people make that choice either way, right? But we just never think about, should I go to penicillin? And so this was fascinating to me. Can you talk a little bit more about this decision, why you felt it was important to evaluate PSSA, and then what you guys found?
So Josh reminded me the other day that Chip Chambers from the US said that he would only believe that an isolate was penicillin-susceptible if God told him that was the case.
Truly, we don't think about it. We don't test for it. We don't report it. So it was important to remember that globally that's not the case.
Yeah, so if you remember back to the discovery of penicillin, Alexander Fleming in 1928 noticed that certain bacterial colonies did not grow on an agar plate as they approached this clump of mold. Now, of course, the mold was producing penicillin, but what we sometimes forget is that the bacterial colonies were actually Staphylococcus aureus. So we know that Staph aureus can be susceptible to penicillin. But pretty quickly after penicillin was introduced in the 1940s, penicillin-resistant strains of Staph aureus were identified, and the use of penicillin fell out of favour, particularly in comparison to these semi-synthetic penicillins, which were stable to the beta-lactamase that inactivates penicillin. However, perhaps surprisingly, in this world of increasing antimicrobial resistance, we've more recently seen a resurgence of penicillin susceptibility across the world. So Sentry data from multiple countries, and I think it's over 100,000 isolates, has shown that by 2016, about 25% of MSSA strains were also penicillin susceptible. The tricky bit is how we test for penicillin susceptibility. You've kind of touched on this, Erin. But the automated antimicrobial susceptibility testing that's done through the Vitek 2 or Phoenix are not sufficiently accurate, and they can miscall for the presence of that beta-lactamase or the BLA-Z gene. So both CSI and UCAST actually recommend phenotypic disc testing to confirm penicillin susceptibility. And this is where a penicillin disc is placed on a lawn culture of Staph aureus. The plate's then read for both the diameter of clearance from the disc edge and for what the zone edge actually looks like. And you need to see both a sufficiently large clearance diameter and a fuzzy zone edge to be able to confirm this as being beta-lactamase negative and indeed penicillin susceptible. And of course, there's some subjectivity for how that zone edge is read. And because of these vagaries of testing, guidelines have largely avoided recommendations for PSSA and defer to treating them all as MSSA with cefazolin or anti-staphylococcal penicillins. So we wanted to test this though, and certainly in Europe and in Australia and New Zealand, people do use penicillin for PSSA. And in this PSSA silo antibiotic backbone domain, we randomised participants to either benzylpenicillin versus flucloxacillin. We had a pre-specified stopping rule for benzylpenicillin to be non-inferior to fluclox. We actually never hit this trigger because the DSMC recommended that we stop the trial prior to reaching this. We started recruitment in February of 2022, and in June of 2024, the DSMC asked the trial steering committee to pause the PSSA and MSSA silo backbone domain because of a signal of acute kidney injury. And when the DSMC looked at a later cut of the data in August 2024, so about 2 months later, they actually recommended not pausing but actually closing the PSSA and MSSA silo backbone domain because of increased acute kidney injury with flucloxacillin. And in the MSSA silo, we had actually hit the non-inferiority trigger for the primary outcome of 90-day all-cause mortality. I might just ask you, Erin, I know you've disclosed before that you were part of the DSMC. What happened at that time? I don't think we're risking trial integrity. We're talking about something that's already revealed now. You're not talking about other domains, but perhaps you can tell us a bit about what it's like being on the DSMC and what its role is.
Yeah, absolutely. I think it's an honor to have this discussion because there has been quite a firewall between us. You cannot discuss this. There's quite a bit of trial integrity here. And so this has been something I've held for a long time. So it's very nice to finally be able to discuss it. I remember I was actually in Australia in 2023 when Steve and Josh asked me to serve on the DSMC. And I remember watching y'all present the camera 2 data at ESCMID many years ago. And that trial was also stopped by a DSMC for more acute kidney injury in the anti-staphylococcal penicillin. That was a much smaller trial. And I remember as an audience member thinking, man, like, I get it, AKI is bad, but it would have been nice to have a larger trial. But this is very compelling. And honestly, since Camera 2 was presented, we have largely shifted to a cefazolin institution and have pretty much been using cefazolin for MSSA bacteremia. So I remember when you asked me, I was like, yes, I absolutely want to do this. And oh my gosh, what if I have to stop the trial? And when you presented at ESCMID, you say it was stopped and the audience is mad at me. And that was like the first thing I thought about. And then that's exactly what happened. And so when we looked at these data in June, it was very challenging to know the right thing to do, because when you're enrolling in a trial as fast as SNAP is enrolling, you stop every 500 patients to get the analysis, but it takes a couple weeks. We're only human, right? The data team works as fast as possible, but by the time we see that data, there were another 700 patients enrolled in the platform at that point in time. And you don't have those data yet, and they haven't hit 14, 30, 90-day endpoints. It's so challenging because you're trying to do the best thing for patients always, but you don't want to stop the largest, biggest, most impressive global effort ever, because if you stop it, who knows if anyone will ever allow you to restart it, right? And we knew that by saying pause, that might also turn off investigators completely. They may be unwilling to resume. And so there was a lot of risk in that too. You don't want to stop the science, but at the end of the day, you have to do what's best for patients. And when we saw that analysis in June, again, it was a little tricky because it hadn't quite hit that trigger. But then when you think about the probabilities and how many additional patients had been enrolled, we actually had an extra meeting to talk about this. We had planned meetings and we were like, this is way too important. So we had an extra meeting to mull this over. And what we decided was the best threading of the needle of this was to not completely stopped the trial when we saw the AKI, and we'll talk about this later, but even a mortality signal, which was really what pushed us over the edge, especially in this PSSA domain. The mortality was double at the time, like numerically double when we saw this in June. And yes, it was much smaller numbers, but that's pretty striking when you look at that and you see that chart. And if I was presenting to a hospital with my mom right now, to what you said, Steve, if you had to talk to them about what you're seeing right now, I was like, would I be comfortable enrolling my mom to flucloxacillin? And the answer was no, right? The answer was no for all of us. But the reason for the pause and not the stop in June was because we wanted to see if we could do an unplanned analysis of all those patients who had been enrolled since that stopping trigger. And I just want to thank the data team because they worked around the clock to do that as fast as possible, because we knew the longer the pause, the more people would lose belief in the trial. And that's really important. And you guys were enrolling like 5-6 patients a day. And so we said that it can't be paused for too long or else it's really going to just throw off the whole thing. And that would be terrible, but we don't want to hurt patients. So that's why we landed on that. If people are wondering why a pause and then a stop, it's so we could get that extra data analysis done. The data team was incredible. And then when they were able to complete that unplanned analysis of all those additional patients, it was clear that, I don't want to give the results away, but it was clear that it had met the non-inferiority trigger, which is such an important endpoint, and that also that there was more harm in the anti-staphylococcal penicillin arm. And so we all were like, whew, okay, not thank goodness that some patients had AKI, but we were like, oh, good thing this panned out the way we thought it was, because stopping a trial is a very big deal. There were some sleepless nights in there for all of us.
Yeah, experiencing a trial hold, trial interruption, it's awful. It's no fun. The world's watching and it feels terrible. You don't wish that on anybody. So Steve, what were the actual results in the PSSA domain?
Yeah, so it's important to note that no trigger was actually met in the PSSA silo. So in some ways we were stopped earlier than we would have preferred. But at the time of stopping, there were 281 participants in the PSSA silo backbone domain, 156 allocated to benzyl penicillin and 125 to flucloxacillin. The participants were reasonably well balanced for baseline characteristics. Median age was 66 and 69, respectively, for benzyl penicillin and fluclox. About 30% of participants were female at birth, and about a third had diabetes. We had very few persons who inject drugs. Intensive care at platform entry was 15% and 9% for benzyl penicillin and flucloxacillin. The primary outcome of 90-day all-cause mortality occurred in 13.8% with benzylpenicillin and 21.5% with flucloxacillin, which was an adjusted odds ratio of 0.67 and what we call 95% credibility interval of 0.35 to 1.28 for that adjusted odds ratio. And the posterior probability of non-inferiority was 0.96 and of superiority was 0.89. In addition to this, the acute kidney injury was much lower with benzylpenicillin at 10.9% versus flucloxacillin at 21.6%, with an adjusted odds ratio of 0.50 and 95% credible intervals of 0.26 to 0.94. And in this case, the posterior probability of superiority was 0.98. So in summary, our results showed a lower 90-day mortality with benzylpenicillin, with a posterior probability of non-inferiority of 0.96 and superiority of 0.89, and also about half the rate of acute kidney injury with a posterior probability of superiority of benzylpenicillin of 0.98. So my big takeaways here were that penicillin susceptibility is real, we can believe it, that penicillin susceptibility testing can be safely used to guide treatment, and in fact, benzylpenicillin is highly likely to be better than flucloxacillin.
Yeah, and I do want to point out too, from the DSMC standpoint, we struggle with that because it was such smaller enrollment in the PSSA, and that was tough, right? And it didn't quite meet that non-inferiority trigger that Josh will explain soon MSSA did. But we also thought practically, and you can't do this, you can't take two arms and combine them, but when you do look at the two arms in totality, and then you think globally, practically most labs are not testing for penicillin susceptibility. And we just thought of that as one variable of, if I'm a clinician looking at Staph aureus, like, do we look at this in totality? And the AKI more than double numerically. It was quite striking. And I'll mention camera 2 again. It wasn't something we'd never seen before. It's confirmatory of a smaller trial. And now we just have, over the years and decades of Staph aureus in totality, you see this consistent signal. So that was also something that made us feel comfortable in stopping.
Very, very impressive results. I'm just going to come back to the whole idea of penicillin susceptibility and testing, and do you believe in it or not? I'll tell you, even inside Europe, even in a small country like Switzerland, there are vast differences. When I first moved to Switzerland, I did my first half of my ID training in Zurich. I felt, coming from New York, I felt like I was going back in time to the 1950s when there was still some, penicillin worked against Staph aureus. It was wonderful. Then when I moved to Geneva, the epidemiology is a little bit more challenging. The labs don't test for penicillin susceptibility. It's just not even in the canon. These are just 3 hours apart, Zurich and Geneva. These are close, these are not long distances, but there's such a difference in culture and practice. So yes, I believe in it. And you showed a very nice slide, Steve, during your presentation. You showed over time the increasing return to susceptibility to penicillin. So I hope that laboratories will be open-minded about this and will return to doing actual penicillin susceptibility testing. A lot of them just don't because, like, I guess Chip Chambers said, I'll believe it when God tells me so, but maybe we don't need that. Maybe we just need SNAP.
It is an extra step, isn't it, to do the disc testing, and I think that throws people off a little bit. And there's still been that question, can you believe those results or not? Well, I think we pretty conclusively show that you can believe those results, and penicillin in this case was better than flucloxacillin.
I will push back a little bit. I think we have to ask ourselves what is most impactful for patient care to ask our labs to do in a world where lab technologists, technicians, medical directors, those are not infinite resources either. Just speaking from my experience, I work with over 16 microbiology labs, and about half of them, I would say, have never performed a disc test. They don't have medical directors. They are run by technicians who work their way up to learn the lab but aren't necessarily trained. And I think this is true of underserved areas, more even in the United States, rural communities, critical access hospitals that don't even have on-site microlabs, things like this. And so when we teach them how to perform e-tests and disc tests, so when we're asking them to bring on technologies, they can only do so much. And so you have to say, is testing for penicillin susceptibility one of the things that they should prioritize bringing into that lab? And that may or may not be a yes, right? But I think these data are super helpful in helping people inform, is this something we want to strive for in using penicillin instead of other drugs for bacteremia, for Staph aureus? But just I'm a big ops girl. So that's what I love about this trial is the practicality of it. You can take these data and actually help your patients with it rather than needing all of this kind of complex care in order to implement this. I think that's what makes this so great.
No, I completely agree, Erin. It's totally complex. There's so many variables we will not have time to go into today. But for example, penicillin, you have to give it more frequently. Is that ideal for the patient, for the nursing staff? Environmental outcomes. I now always think about environmental outcomes since we did that communicable episode with Shreya Doshi, and what are we costing our environment when we have to use material and administer something 6 times a day as opposed to simply a drug that doesn't need so many daily administrations. The SNAP, in so many ways, it answers questions, but it's also asking more questions. So moving on from there to the MSSA domain. Josh, can you tell us what happened there?
Yeah, sure. And reflecting on what you just said, I don't think I've ever read the results of a large clinical trial that didn't leave you with more questions than it answered. So I don't think we're
directions.
alone there. Yeah. So the MSSA part was a lot larger than the PSSA part simply because MSSA bacteremia is more common than PSSA bacteremia. And when we're saying methicillin-sensitive Staph aureus, we're using that as a shorthand for methicillin-sensitive but penicillin-resistant Staph aureus. And that's an important point because some people just lump them all in together, and that will bias towards finding non-inferiority of cefazolin. So we excluded penicillin-sensitive from the MSSA group. So we ended up with 1,341 patients or adults with MSSA bacteremia randomized to flucloxacillin or cefazolin, and 670 got flucloxacillin, 671 cefazolin. It was actually cloxacillin in some countries because that's what they used, such as Singapore and Israel, for example, and flucloxacillin in others. So that's the numbers. The baseline characteristics of the populations were pretty well matched, and they're quite similar to what Steve presented about the PSSA part of the trial. We hadn't mentioned before, how did we get so many patients in a trial? How do we recruit so quickly? It's because there's a lot of sites. There were around 100 sites participating in this part of the trial, and there's now over 120 active sites, and that's across 9 countries. We need to thank all of the investigators at all the sites and all of the teams at these hospitals for making this possible, because we can come up with an idea on a napkin and design it and activate it, but it would just be nothing unless there are lots of hospitals willing to join it.
Josh, I'm glad you said that because I wanted to mention in the intro and I forgot, but for the listeners to scale the enormity of what Josh just said, there are over 450 global investigators and over 325 staff, I think are the stats you guys presented. That's an insane amount of teamwork. So yes, I think it's important to underscore just how big this effort is.
Yeah, and most of those people are doing it just for the love of it. They're not getting paid or they're not getting anything special out of it except for knowing that they're contributing. Except a lot of them are getting authorship on the papers that we're writing. So those were the numbers. The primary outcome was 90-day all-cause mortality, and that occurred in 17% of patients in the flucloxacillin arm and 15% in the cefazolin arm. That's the raw data. When that was put into the model, the adjusted odds ratio for mortality was 0.81 with cefazolin, so less likely with cefazolin, but the credible intervals crossed 1. The probability of non-inferiority was 0.9922, so 99.2% probable that cefazolin's non-inferior to flucloxacillin in terms of mortality, and the probability of superiority was 89.8%, so around 90% probability from this model that cefazolin was not only non-inferior but in fact superior in terms of mortality. So that was the mortality outcome, and that non-inferiority trigger was met because it was more than 99%, like Erin alluded to. But the other side of the coin, which is as important, if not more, in the decision to cease this part of the trial was the acute kidney injury endpoint. So acute kidney injury happened in 19.1% of patients in the flucloxacillin group and 13.7% in the cefazolin group. And again, feeding that all into the model, the adjusted odds ratio was 0.67 for acute kidney injury in cefazolin versus fluclox, And the probability of non-inferiority there was 100% and of superiority 99.7%. So very clearly, cefazolin causes less acute kidney injury than flucloxacillin. And even though this may sound kind of obvious, like if you look at all the observational data, they all suggest that acute kidney injury is more common with fluclox, but I don't think it's obvious. I think it's important to point out there's never been a randomized trial that have randomly allocated patients to these two types of antibiotics before and looked for acute kidney injury, because it's quite possible, or it was possible, that in the observational data we're seeing a difference because of other differences in patient characteristics. For example, patients who are sicker, clinicians choose to give them flucloxacillin, and they may therefore also be more likely to get kidney injury. So Erin did allude once or twice to the CAMERA-2 data, which showed increased acute kidney injury with fluclox, but that was the combo of fluclox and vancomycin versus vancomycin alone. That wasn't flucloxacillin versus a different antibiotic. So I think even though it may seem obvious, it's not necessarily. And it did turn out that what we suspected to be true was in fact true, that flucloxacillin, it's not just associated with acute kidney injury, it causes acute kidney injury. There are a number of other outcomes, but those are the two really important ones, mortality and kidney injury. And for me, the conclusions are that flucloxacillin actually is nephrotoxic. It's not just an epiphenomenon. And that cefazolin, there's a lot of theoretical concerns about it may not be as good as flucloxacillin, but those theoretical concerns really just were not borne out.
We also looked at the endocarditis subgroup, because that's the group where there's the particular concern with the cefazolin inoculum effect, because it's a high inoculum infection. I think there are about 100 patients with endocarditis, and the treatment effect estimate was very similar for that subgroup as it was for the rest of the non-endocarditis patients. So that also provides us with some reassurance that where there's a high inoculum infection, that this theoretical issue of the cefazolin inoculum effect probably is not clinically relevant.
Steve, I'm glad you said that, because I wanted to call that out, that 8% of the patients in this cohort had endocarditis and 0.5% had CNS infections. And so super small with the CNS infections, but I think it's very important for listeners to know that you did not exclude CNS infections as entry into this. And that is, thank you. That's amazing that you think there's equipoise to study this. Hopefully you can include more patients with CNS infections in the registry study, and we can see moving forward what that looks like. But people still have reasonable concerns about this lab phenomenon, whether that's clinically relevant. But I think what we're looking at is an unbelievably large amount of patients and showing that cefazolin was non-inferior. So you're looking at this inoculum effect on a population level in real life. And even though endocarditis and CNS were small, there's a pretty high bioburden of infection with a lot of Staph aureus outside of those two indications. And so I think we're seeing that the clinical relevance of that is maybe not there in a very large cohort of patients with staph.
I was just looking at our data today, and there were 90-odd patients with epidural abscesses in this data set. And, you could argue whether epidural abscess is a CNS infection or not. We coded them as not being a CNS infection because you don't need to get through the blood-brain barrier to get to the epidural space. We haven't actually looked at the treatment effect estimates for that subgroup, but it'll be pretty interesting to look at that. And again, that might provide further reassurance for maybe a CNS adjacent kind of infection.
I love it. People always say, where's the data to use cefazolin for CNS infections? And my response is, where's the data to use flucloxacillin for CNS infections other than that's what we've always done? So it's amazing. I love that it's included, and I'm excited to see those patients continue to in the registry, since of course they can't be randomized anymore to the backbone. But
I just want to go back quickly, Josh, to the results of AKI. What do you think is the mechanism of the nephrotoxicity? Is it pre-renal? Is it the salt load? Is it a direct toxicity? Are you going to be able to look at this? Do you have a subgroup?
So we're not going to be able to directly look at it from the SNAP trial data thus far, but there are a number of avenues we're going down to look at that. So one is we're collaborating with Mark Sheets from Midwestern, who's got some animal model and mechanistic research going on to try and unravel this. Also, Steve and I, one of our PhD students was looking into this and was looking at urinary biomarkers from patients enrolled in SNAP to try and unravel the mechanism a little bit, and those data are still being analysed. My feeling is this: previously what people used to say is, oh, look, patients with staph bacteremia get acute kidney injury because they're sick, they're septic, they've got kind of infection-related glomerulonephritis, it's not from the antibiotics. That's what the nephrologists used to say. And then other people would say, no, actually the antibiotics must be causing allergic interstitial nephritis, some kind of acute interstitial nephritis, not a dose-related problem, but an idiosyncratic problem. But how I interpret our data is neither of those things are true. Staph aureus bacteremia does cause a baseline degree of acute kidney injury, but flucloxacillin is, I think, directly toxic to the kidney. I don't know which cells within the kidney. There is some mechanistic data and that may relate to OAT receptors and uptake of drug into cells and so on, but that's still being unraveled.
I will say, Josh, on that note, I couldn't agree more. And in this same session, there was another trial presented called the Cloceba trial, which we're not covering today, but if you're a Communicable listener, and all the Breakpoints listeners, you should go listen to Communicable for this. And then coming few weeks, we're going to do the ESCMID late breakers, and we'll cover the Cloceba trial there. It was also a Staph aureus trial, and their investigators showed a safety slide, and this really stood out to me. It's one of those supplement tables I'm going to pore over and include in the future. But they actually showed their patients over time in enrollment, and the patients enrolled to the cefazolin arm for them, their creatinine on average over time went down 13 points, and the patients enrolled in the cloxacillin arm, creatinine went up 8.9 points. So to your point, you come in with septic shock, whatever, you have staph bacteremia, you have AKI at baseline, cool, right? We know that happens. What that actually showed me, and again, it was like one slide for a second in the presentation, so I need to dig into this further later, but what that actually showed me is like patients who got cefazolin, their AKI improved, whereas patients that got cloxacillin, it got worse, which is even more telling and super important. So we'll unpack that more in the future. But Josh, everything you just said, I totally agree.
And I've got to ask you one more question, Josh. In the MSSA domain, certainly PSSA I don't remember, but the MSSA domain, the early mortality endpoints, so 14 days, 28 days, 42 days, they all show an even greater reduction in mortality with cefazolin than we see at day 90, which is where the primary outcome was measured. And it's funny because a year ago, Erin and I did our first Communicable episode on ESCMID Global late breaker trials from 2024, and I remember musing that maybe a 90-day time point is too far out. Trial participants start to have events like mortality, for example, that may have nothing to do with the initial intervention that you randomize them to. The numbers even out over time, and maybe we're all making a type 2 error, concluding no difference or little difference when there really was a difference. Then a few weeks later, when we did the Bling 3 episode with you and David Patterson, we learned that you, Josh, had done your PhD work on time points for studies, and you found significant differences in mortality, especially at 90 days. I still wonder, though, and admittedly I have not read your dissertation, do these SNAP data change anything for you? How do you fit this in now, with these earlier time points showing more mortality benefit than that 90-day time point?
Personally, I would love to take credit for the time points being used in trials around the world, but that preceded me looking into it. And secondly, my PhD was on a number of things. That was just one little part of it. But what particularly I found, but others have found as well in patients with acute severe infections, is that people die at a higher rate than a controlled background population, like of the same age and comorbidities, for up to 2 years after the episode of infection. They're dying more than they should for up to 2 years. There's a lot of mechanistic work that's shown with a number of acute infections, including COVID, pneumonia, sepsis, that patients get endothelial activation and an increased risk of vascular events like strokes and heart attack for at least months after an insult like this. So I think it's a mistake to use earlier time points. I agree with what you're saying. The longer you get away from the initial insult, the more that noise enters the system and things like cancer and other causes of death enter the system. But what I would say back to you is, let's just say I've done a trial and I've shown this particular intervention improves mortality at day 28, but there's no difference at day 30 or 90. Would you want that intervention if it just delays your mortality rather than prevents it from happening?
If you put it that way, of course not. That's how you frame the question, Josh.
I was like, wow, that was powerful, Josh. I was like, no, I don't. I want to live.
No, of course.
No.
Yeah,
I mean, it is an ongoing debate, Angela. You're right. I think 90 days is the kind of compromise that most critical care trials have come to, because there are people pushing
Definitely.
for later time points, like 1 year outcomes. And traditionally in the past, people used to always use like 30 days up until maybe a decade ago.
No, I agree that 30 days is too short. Ideally, you don't have to choose, right? You do them all, you measure them all up to at least 90 days. And then you don't have to choose because your readership, ideally, is not only reading your primary outcome results. They're not just reading your abstract. But anyway.
Hopefully.
Originally, it was just 90-day mortality, but we are, in fact, looking at later outcomes at the request of our consumer reference panel, not mortality endpoints, but quality of life endpoints, because they were like, well, what happens 1 year down the track? What's quality of life like in the two different groups and so on? And we're like, oh, we don't know. So we're adding those elements into the trial as well.
I think it's awesome because I'll admit, and I've said this on many a podcast episode, if people go back and listen, I was a hater of the 90-day endpoint for acute infection to start. It didn't make a lot of sense to me, but the more we do this and the more I learn and realize we grow, it makes a lot of sense. And I think exactly what you're saying is true in that this sepsis episode or this how this index infection is treated really does impact your outcomes down the line. Something that really solidified this for me, actually, and Josh, I'm thrilled to hear, and Snap, you're extending this longer, was when the POET trial, another Staph aureus bacteremia trial, of course, they published their 5-year outcomes. And honestly, this kind of was like a sneaker publication. It was like a tiny little editorial thing in the New England Journal, like a column in a newspaper. But it is amazing data, and the difference in patients who had early oral switch persists out to 5 years in them having better outcomes, which is unreal, right? When you think about that, and it's like, wow, how did just not having a PICC line 5 years ago really improve your life that much? But evidently it did. And so that was a real shift for me, and like, wow, I'm thinking about this wrong. We need to start looking at how we treat acute infection. And to your point, the impact on your long-term outcomes, because that's the long game, right? If you live to 28 days, that's great, I guess. But really what you want to do is make it to your grandkid's next birthday, right? So we really want to look at patients out years and years. So I think that's very cool. And the other thing that's cool is that we've been through all of the results. And I just want to take a moment and guys, like, this is so awesome. And I think this session was, as I said in the beginning, structured wherein you presented data, the placebo authors presented their data, and then there were 2 experts that provided commentary, which was such a neat thing. And so clinical commentary was provided by Vance Fowler, who's a world-renowned staff researcher, and then reflection on trials in general and trial design was provided by Julia Balicki, who was incredible in what she went through in teaching the audience about trials again. Something Vance said really stuck with me. He got up and he said to the audience, if this doesn't seem like a big deal, then you're not paying attention, which is so accurate. This is a huge deal. So Steve, you want to just take a moment to reflect on how cool this is?
Yeah, it is sort of when you do step back, we're obviously in the weeds of all this and you don't see the kind of forest for the trees. But when you do step back, it is a pretty amazing thing. The most gratifying thing perhaps was when people started saying, look, I think we will change our practice. We will stop using flucloxacillin and we'll switch to cefazolin. We need to start talking to the drug suppliers. We need to start talking to our regulators about switching to cefazolin. If that means that there's hundreds, thousands of patients around the world who get less acute kidney injury and who survive, well, that's amazing. And if the fact that we presented it at a big forum like this pushes people along that track, I think that's what we're in the game for, isn't it? It's for our patients. It's for seeing that they have better outcomes because of the work that we do.
It is amazing. And I think what you just said there is important in the audience response part, which was, again, awesome. How much time was dedicated to allow people to ask questions and have dialogue with you guys. I'm sure that's so helpful as you're writing this manuscript. You've already gotten this peer review format. Someone in the audience did say, my country doesn't have access to cefazolin. What do I do? What's y'all's plan to talk to regulators and make it so that we can get this drug now? And if your country doesn't have access or your institution doesn't have access to this agent, perhaps it's time to start having the conversations about how to get your patients access to this drug. But Angela, can you tell us a little bit more then about how ESCMID decided to support this new format for presenting ID trials? Because that in and of itself is also quite a feat.
It was a very experimental session. ESCMID hadn't done anything like this. We're giving so much time to just a couple, 2-3 trials, giving a full 2-hour run. And in fact, they called it the trial run session. The idea came to them actually only through me. I was just a conduit. It was really Steve Tong and Josh Davis, who wrote a beautiful email, Steve, back in February, I think. You wrote an email with, I loved the subject heading. It was Dreaming of Clinical Trials in ID. And you had just come away from this famous critical care conference where they give, I think, a 2-hour session to one trial when they really get to pick it apart. The audience gets to interact. People get to really learn how the trial worked. They learn the pitfalls, I think, of trials. It's really good exposure to the audience who then understands, hey, it's not that easy to pull off a good trial without any limitations. That's not real. That doesn't happen. So thanks to your email back in February, I was able to talk to the program director of ESCMID Global, and thanks to his incredible flexibility, this is Jacob Moran-Gilad, very receptive and very flexible. We're talking February, ESCMID Global's in April, and he said, yeah, let's try this out. So they were able to create this new session that I, again, sadly could not go to, ironically enough. But I think what's important, though, to know is that in no way did SNAP get actual preferential treatment to be the contents of the session. Definitely Steve and Josh triggered the creation of the session, but Jacob was very careful to submit all the trials, all the late breaker trials that were coming in to the standardized approach. They all underwent this open call, and the program committee selected, okay, which trials are going to be granted this extra special experimental session, not knowing at any rate if this session would work in our field, in our framework. Steve and Josh, I bet you want a little feedback on whether it worked or not. I'm not part of the program committee, so I don't know what my impression is worth, but everyone I've talked to has been really impressed on all levels of training. The younger, early career people I've talked to have been really happy that there was this time given for questions, that we had the two moderators, Julia Bieliecki and Vance Fowler, sort of explaining, putting this trial in context, both on a clinical level and on a trial design level. So the feedback I've gotten has been only positive. I don't know about you, Erin.
Oh, it worked. It was fantastic. ESCMID should definitely keep this platform, and I'd love to see the ID space move into what our critical care colleagues have done. Because when you have 10 minutes to present a decade's worth of work, for example, the BALANCE trial, right? That was presented at ID Week, and that was a decade-long trial that enrolled thousands of patients to define what the duration of bacteremia is, and Nick Damon had 9 minutes to present it. I mean, that just doesn't do it a service. And so this really let us get into the weeds of it to understand the decisions that were made, even from it started on a napkin in a bar in Melbourne, and here we are. So that kind of stuff is very neat to hear. And I do want to end this episode with going through some of those audience questions, if that's okay, guys, because I think that's what the neatest part was. It was like you're having this real life journal club in front of 6,000 of your best friends with a moderator, right? So I'm going to pull 3 of them. There were dozens of really good questions, but I'm going to ask you guys 3, okay, and kind of rapid fire, end the episode with some zingers here. So I liked this one a lot. Someone asked, do these results apply to non-bacteremia staph aureus infections, such as bone and joint? I think we treat a lot of osteo. Steve, thoughts?
Yes, I believe that the toxicity we saw with fluclox will still be there regardless of what you're treating, particularly the doses that were used. So we used 2 grams Q6 hourly, and that's probably typically what you would use for bone and joint infections. So certainly for me, I've moved away from using flucloxacillin in such circumstances and would preference cefazolin.
I'd co-sign that. Like Josh said, I think fluclox is toxic, so that's going to be true whether you're treating skin, bone, blood, what have you. Okay, Josh, the next question that was fantastic was, should these adult data change my practice in peds?
Yeah, and as I said, when someone asked that, thank you for asking that, because it's really important for us to have a chance to let people know that, no, they don't apply in children. And in fact, we're continuing to enroll children in the pediatric part of SNAP in this comparison, cefazolin versus flucloxacillin or cloxacillin, and that's because the number of children enrolled is obviously a lot smaller, but there's been no signal of kidney toxicity with flucloxacillin in the pediatric population, and the pediatricians that are running that part of the trial were very keen on continuing that and trying to learn what is the best antibiotic in children. They clinically don't feel like they see acute kidney injury in kids with staph bacteremia very much, and they don't feel like there is a signal with flucloxacillin clinically, let alone in the trial. So that's continuing in children.
Yes, and I think from a DSMC perspective, we agreed with that. We said you can continue in peds by all means, but we did say you have to include in the pediatric consent that this signal was found in adults. I do think, though, for the peds folks out there, we should consider anti-staphylococcal penicillins as nephrotoxins. And I know in pediatrics, we're often a lot more judicious with labs because we're a lot more thoughtful about taking blood from peds. And so I would just say that if you're and in the trial, of course, you're doing labs, but out there, if you're not in the trial, you should maybe be checking serum creatinines in pediatric patients on these anti-staphylococcal penicillins now. I think they go on your ninja list if you're a part of the nephrotoxic in peds. There's a very large study looking at those drugs. I think you got to add this one to your list. Okay, last audience question that I thought was fantastic. So Julia, again, who is just such an exceptional moderator. Angela, I think you recommended her 10 out of 10. She was fantastic. She mentioned one of her mentors and colleagues, Sarah Walker, and said that Sarah taught her the concept of being a trialist and having this anticipated regret, which I was laughing because I'm just starting to dip my toe in running trials, but I've collected a lot of data in my life. And when you build a data collection tool and you start to look at your patient charts and you're reading, always you get to patient 142 and you're like, oh, I wish we would have collected this. I mean, we've all been there. So I loved that. I was like, I've definitely had anticipated regret in designing studies. There's going to be something you're like, I wish we would have done that. So the question was, did SNAP have any regret now that we're where we are? Steve, do you want to take this one?
Most of the trials and studies I've run, we've collected too much data, Erin, not too little, and we find that so many of those data points don't actually get used. We in SNAP made very deliberate decisions to only collect data that were important for their outcomes and potential confounders and obviously the safety things as well. So we've tried to minimise things. I think that's been the right decision. If there's anything that I've regretted a bit is perhaps we've made some things too complex actually. With the database, there's all these kinds of time-based logic within the database that we're having trouble now unpicking as we're trying to introduce new domains and change certain things. So, one of my lessons has been actually keeping things simpler for this kind of pragmatic trial would benefit us both at the initial phase, but also at the phase now. And the more secondary outcomes that we're pre-specifying, the more work there is to collect data for those, as well as do the analysis. And the analytic team pulls its hair out when we say there's what we call estimates, 30 estimates that you guys need to model. And they kind of say, well, that's way too many. Each one takes X amount of time. So if there's actually any regret, it's that perhaps we should have kept things a little bit simpler.
Yeah, that's really interesting. We're living in an age of electronic case report forms, so I imagine you don't really have one on paper, but if you had to, how many pages would you estimate your CRF is?
There's the platform level and there's domain level.
Josh, gotta put it to paper.
Okay, for someone in the backbone domain, it would probably be somewhere like 8 to 10 pages of data that's being collected.
Yeah,
and,
that's a lot. That's a lot.
Yeah, it's a lot less than. I mean, Steve and I had to continuously say no to people who wanted to add more data points, right? We had to hold firm on that and really only collect data points that you could really justify were going to be important. And even then, I think there's some that we're never really going to use.
That's a good message. Yeah. You always figure, I'm going to do this trial once and I want to get everything I can. Like Erin says, I don't want to miss anything on patient 142. But in order to actually ensure feasibility, you can't make it too heavy and too complicated.
This episode has been much longer than our typical hour, but I think it's been worth every second. I always love talking to you guys, and I think we are all richer and better for having learned about how you design this trial, the results of this trial, and what we're going to do moving forward. So I want to end with that final line. Has this changed your practice, Fen?
I'll start. Absolutely. For me, I've stopped using flucloxacillin largely, switched over to cefazolin for any staphylococcal infections, and we've seen that shift at my hospital as well. So for sepsis in general, we used to use flucloxacillin plus ceftriaxone as our standard community-acquired sepsis therapy, and a lot of people have switched to ceftriaxone plus cefazolin now.
Yeah, and for me also, it has changed my practice. I've switched. Flucloxacillin was the standard therapy at my hospital and in my practice for MSSA bacteremia, and it's now myself and all my colleagues, because I've told them at my hospital, have gone to cefazolin, and we're going to be working hard to get this into clinical guidelines, both in Australia and elsewhere, and ditto for penicillin for PSSA.
The last thing for us as well, can we just give a great shout out to everyone who's been involved in the study? I think, Erin, you mentioned the hundreds, it's really actually thousands of people around the world who've been involved, the thousands of patients. And I always say for each trial coordinator at each site who screens a patient, even when the patient says no to the consent, they've still spent that time and efforts to go and identify that patient and speak to the patient. And every single minute that people spend contributing to this really does contribute, and we're only where we are now because of that global community.
Thank you so much to them and to our guests, Steve Tong and Josh Davis. So while we're wrapping up here, we're not entirely done with ESCMID Global. In the next Communicable episode, Josh and Erin, both editors at CMI Comms, get together with fellow editors Emily McDonald and Mark Bonten to unpack other late breaker trials to understand whether their results should change your practice or not. But for now, thank you for listening to Communicable, the CMI Comms podcast, and Breakpoints, the Society of Infectious Disease Pharmacists podcasts.
This episode was peer-reviewed by Megan Klatt and Lacy Worden. It was edited by Julie Anne Justo and transcribed by Katie Lambert and Sarah Groome. The Communicable theme music was composed by Joseph McDade, and the Breakpoints theme music was recorded by SIDP member Dr. Steve Smoke. You can subscribe to both Communicable and Breakpoints on Apple, Spotify, or wherever you get your podcasts. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along, and helping SIDP achieve our vision of safe and effective antimicrobials for now and the future.